Okay, we are going to start now. There are a couple of questions I'm getting here. I'll try to answer as many questions as possible. We are live on YouTube as well at the same time. And many of you are also joining us from Zoom as well. Now, the first question I have here is, will classes begin from Monday next week at the same time? I'm not sure what you are actually trying to ask, because the classes happen once every week and happens at 6:30 of the Australian time, Melbourne and Sydney time. Generally, I do it on Wednesday, but sometimes I do it on Tuesday. Whenever I'm going to do it, you will get some notification or some information from me on the Telegram group or on the other group we have, the Facebook group. Okay, now moving ahead, let's talk about some of the cases. We don't have much time to spend on other things today. Unfortunately, we'll try to go through the cases as quickly as we can. We have 3 important cases to discuss today. After every case, I'll give you some time to ask me questions. So if you have any questions, please feel free to ask me those questions. The first case we have here is a case of the 44-year-old lady with reflux and heartburn for the last 1 year. And the question we have here is, generally in the PESCI, what happens is they ask you to do everything. That means they ask you to take the history, they ask you to talk about the physical examination, then investigations, and then after that, also the management of the patient. So PESCI is a comprehensive interview where you have to show that you are able to handle the patients you'd get in the real practice as a general practitioner. So you need to have a basic understanding of how to take the history, what kind of examination you can quickly do in a general practice settings, what kind of questionnaires you can use as a general practitioner, or what kind of office test you can do in the general practice. Then after that, you should have a good understanding of the investigations you can do or you should request, and then how to interpret those investigations, how to start the patient on any kind of treatment, after that, how to follow up the patient, and so on. So this is what we'll be talking about here. One of our friends is asking something on our group. Okay, so she needs the passcode to join the class. Just give me a second. I'll quickly share the passcode. Our passcode, those of you who are joining on Zoom, the passcode is PESCI 2024 if you want to share it with others. Otherwise, the passcode is already available on the website as well. Anyway, moving forward with the case here now. So how would we approach the case? Now, those of you who have already taken my course, you know that I always use a structured approach for asking the history. The structured approach that I go through is I start with the history of presenting illness, then red flags, then differential diagnosis related question, then past medical history, where I focus in the past medical history relevant to the case, then past medical history in general. I ask about the medications and allergies, then I ask relevant psychosocial history and family history. So this is my general approach to history taking. In any case, I try to do as much of this as possible. This makes my approach structured and I'm less likely to miss any important questions in the exam. Because PESCI is more about how you present the case or how you speak with the role player. As long as you are structured, you are less likely to miss, and you will also sound more confident. So I suggest that any one of you who is preparing for your PESCI, make sure that you have a structured approach. You have a proper way to take the history in a structured, streamlined manner. Also, make sure that you don't waste your time asking the fluffs. That means asking the questions which are not relevant to the case. Yes, having a structure is important, but not all the time you need to ask all the questions in the structure. So this is your responsibility to learn the importance of different questions in different cases. Okay, so how would we do in this case? Let's talk about that. Now, these are the questions. Now, if you look at the questions here, you might feel like these are so many questions. How would I remember all of these questions to ask in the exam? But if you think about the structure that I have been talking about, these questions are actually quite easy to understand, easy to remember, and easy to ask as well. What I mean by that is, if you look at here, The first question I have asked to this patient is, can you tell me about the main problem that brought you here today? That means I'm just asking the patient an open-ended question so that they can share the opening statement with me, so that they can tell me what is wrong with them. Rather than asking the patient directly about the symptom, although the symptom here is heartburn, rather than asking the patient directly about the heartburn, what I'm saying here is, tell me why you are here. This is an opportunity for the patient to speak up. Now, the benefit of this kind of question is, maybe while answering this question, the patient might as well answer these questions at the same time, even before I ask them, because it's the patient who will decide how much information they want to share with you. So give them an opportunity. It will save you time. It will give them an opportunity to help you as well. One of the common problems that we see in the exam is some of the doctors start asking the closing-ended questions too soon. If you do that, then what the role player will do is they will be a bit reticent and they will start only answering your questions, which means unless you ask all the important questions, they will not help you. So these are not role players who are uncooperative. These are the role players who have been switched off by your early approach to closed-ended questions. So give them an opportunity to share the information with you, and then depending on how much you have got, try to ask the rest of the questions. The rest of the questions here, they are based on an approach that we call Socrates. So what is Socrates? If you have already gone through the history taking video I have on the course, perhaps you already know what is Socrates. Socrates is the short form for site onset character, radiation associated symptoms, then timing and trigger, exacerbating and relieving factors, followed by the severity of the condition. Sometimes you might find all these questions relevant. Sometimes you may find just some of the questions relevant. As much as possible, try to ask the questions which you think are relevant. This will require a little bit of practice. What I suggest for those who are just getting started is have a list of all the common presenting complaints you get in general practice and practice asking the Socrates questions for each of those presenting complaints, and make sure that you can ask questions without feeling confused. You can speak fluently. You have proper structured questions to ask the patient without confusing them, because English is not the first language for many of us. We have to think about it, and in the exam the only thing we don't have is the time to think. Unless we are structured, we have a streamlined approach, we may not have enough time to think and then formulate the next question. That's why these things should be in your head ready-made. You should be ready to fire these questions. So here the questions I'm asking, where exactly do you feel this discomfort or burning sensation? This is about the site. If they have already given me this information, I'll not ask. If not, I'll ask this question. And then I'll ask about the onset. When did you first notice these symptoms? Then I will ask about the character. Can you describe the sensation? Is it burning, feeling, pain, or something else? If I'm not clear about that. Then I can ask about the associated symptoms. Radiation. Does the discomfort spread to any other areas like your throat or chest? Then after that, I'll ask about the associated symptoms. I may have more than one question to ask in associated symptoms. Most often, associated symptoms are the questions related to the clinical features of the provisional diagnosis in your mind. Sometimes you may not have any provisional diagnosis in your mind by now. It might be too early for you to come up with that. If that is the case, it's fine. You can skip these questions and ask them later on after finishing all the other questions. In my case, I generally do not ask the associated symptom questions because I find it too early to ask these kind of questions. And I feel like it will make me a bit biased if I start thinking about provisional diagnosis too early in the history taking. So questions I can ask here, are there any other symptoms you have noticed along with the heartburn? This is an open-ended question. If you have any idea about what those other symptoms could be, depending on what diagnosis you are thinking, you can simply ask those questions directly. Then I'm asking about the timing and trigger. How often do you experience these symptoms? Is it constant or does it come and go? Have you noticed anything that seems to trigger or worsen your symptoms? So you can see that these two questions are telling me about the timing and trigger. Then I'll ask about the exacerbating and relieving factors. Is there anything that helps relieve your symptoms or anything that makes your symptoms worse? After that, you can ask about the severity. Now, when we talk about severity, severity can be quantified objectively in case of some symptoms, but the other way of asking about the severity is to ask the patient how it is affecting their daily life. This is a very good way to understand how distressing the problem is. In some cases, what we need to remember is, even if we think the problem is not that much bad or that much serious or life-threatening, the patient might think otherwise. As an example, an adolescent patient, 14 years old patient coming with acne, who, let's say, that has just a few acne on the face, you may feel like, no, this is not a serious condition, but the patient might be quite distressed. They may say like, I can't go to university because I just feel so embarrassed. I just feel that I am not looking good. I have lost my confidence. So although the problem from the medical point of view may not be a serious problem, from the patient's point of view, it has been quite disabling. So ask the questions about severity, not just from the perspective of quantifying the severity of the symptoms by asking questions like, on a scale of 1 to 10, how would you rate the severity of your symptoms? Also ask them how it is affecting their activities of daily living. You can also ask, have you ever woken up at night because of your symptoms? That's another way of assessing the severity of the symptoms. Nighttime symptoms usually indicate the problem is quite severe. Many of the psychogenic problems disappear when the patient is sleeping. But if they still have the problems even after sleeping, it indicates that this is not something that we can just take lightly. It's more serious. Okay, so this is the history of presenting illness. How do we ask the questions? By using the Socrates. How do we practice this? Just find the list of the symptoms that patients often present with, and then practice yourself under timed conditions to ask all these questions as you find relevant. The more you do, the better you get at this. And let me tell you, if you practice it this way, if you practice in the right way, when you will start working as a general practitioner, you will feel much better approaching your patients. You will feel like you are more fluent, you sound more confident, and you can get information from the patient more easily, which will also help you in making a diagnostic formulation. So this is the history of presenting illness. What is the next thing we do? We have to remember to ask red flags. This is again my way. You may ask about red flags at the end. You may ask about red flags somewhere in the middle. That's fine as long as you remember to ask. But my way of doing things is I first want to make sure that I'm not wasting my time asking the other questions when there are some red flag situations which I need to address immediately. So I immediately ask about red flags. And also make a habit of thinking about what are the red flags for different presenting complaints. What would be the red flags in headache? What would be the red flags in rashes in a child? What would be the red flags in someone presenting with UTI symptoms? These kind of things. Try to think. And if you have a list of the red flags for different presenting complaints, you are less likely to miss any serious conditions, not just in the exam, but also in the daily practice. And anyone who is able to ask the history of presenting illness and red flag questions is less likely to fail in the exam because they will not miss anything that is important or serious. And it also shows to your examiner that you are structured, you are a safe candidate. So red flags in case of heartburn, what are the things I need to think of? Any unexplained weight loss. Why this is a red flag? Because unexplained weight loss might indicate malignancies. So I want to know about that. A severe dysphagia or odynophagia or malignancies can cause unexplained weight loss. That's why I would want to know about that. Not just that, I will also ask about any pain or difficulty in swallowing to know about the dysphagia and odynophagia directly. I can ask about any vomiting, especially with blood. That can give me an idea about the hematemesis, and that can tell me about any esophageal varices. Have you noticed your stools being black or tarry? This tells me about the person losing blood in the stool. Though this can give an idea about the ulceration. Do you ever experience chest pain along with these symptoms? The chest pain along with the symptoms could just be because of the severe reflux itself, or can also happen when there is aspiration of the acid, and that can also cause this. Do you ever experience chest pain along with the symptoms, and have you developed a chronic cough or hoarseness? As we know that gastroesophageal reflux is one of the common reasons for chronic cough. And not just that, it can sometimes when the acid reaches the larynx or the vocal cord, it can cause the hoarseness as well. So these are some of the things that I want to quickly ask to find out how severe the problem is and whether the problem has increased in its severity or I need to act more quickly. The red flags questions are even more important for general practitioners because it will help you in determining whether the patient needs to see someone else or not. So I can make a decision about whether this is a problem that I can solve myself or I need to take help of others. And when I think about taking help of others, I can also think about the urgency of that help. Does this mean I need to send the patient to the emergency? Does this mean I need to send the patient to the specialist, but they can wait? So red flags questions in general can help me in making decision about whether I need to act right now. I need to act in the sense of sending the patient to the specialist, but I have a little bit of time to do that, and so on. So That is one of the reasons I ask the red flags questions before I think about anything else. Then after this, generally ask about the differentials. Like if someone is presenting with this kind of symptoms, what could be the differentials? In some of the cases, you might just know the presentation is very specific, very typical. So you may have very few differentials. In some cases, the presentation can be quite vague and you may have a lot of possible conditions coming to your head. In the exam, at least try to practice to think of 3 differentials. And the way you should practice this is try to think of 2 which are very common, 1 you should not miss. You can have more than 3, of course, but at least in every presenting complaint, if you can think of 1 diagnosis that you should never miss and 2 diagnoses which are very common, you are less likely to make mistakes in the exam or miss the diagnosis itself. Now moving forward, what are the other things we'll be thinking about? Review of the systemic symptoms. Sometimes when the presentation is vague, you can think about the systemic symptoms. Systemic symptoms or review of the systems usually means you go through each system thinking about what could be one relevant question to ask here. In this case, we don't have much, but we can ask 2 things here. I can ask about the fever, fatigue, or significant changes in weight. But most of this information I already have, especially the weight. And I can also ask about, have you noticed any changes in your bowel habits? These 2. This will give me some ideas about my possible diagnosis here. Moving forward, the next thing I want to ask here is, the next thing I want to ask after this is the past medical history. So in the past medical history, what should we know about? Past medical history, again, in the past medical history, it can just be something non-specific or non-relevant or something which is very specific. Try to think of anything that you think could be contributing to the patient's condition first. And then try to think if there are any other past medical conditions. Because as a general practitioner, you're not just making the diagnosis, you're also helping the patient in several other ways as well, which means you might be responsible for the patient education, preventative activities, immunizations, those kind of things. That's why you are not just dealing with the case you have in front of you, you are dealing with the person. That is one of the basic differences between hospital practice and the general practice. Hospital practice is more about fixing the problem. General practice is more about helping the patient overall. That's why you are approaching the patient as a whole, not just for a particular condition they present with. And they often encourage us to ask the questions which may not be directly relevant to the patient, but is important for the patient's overall health or for the community health. So here, for example, if I'm not sure what question should I ask or which condition can contribute to general gastroesophageal reflux in general, I can ask a general screening questions like, do you have any other medical conditions we should know about? Are your health screening up to date? Because as a general practitioner, this is my job to make sure that these are up to date. And then about the medications, like what medications are you currently taking, including over-the-counter drugs. Now, in this case, the patient might tell me that they are taking Gaviscon, which is an antacid. They might say that I'm taking some S2 blockers, and that's fine. In the exam, sometimes they will tell you the brand name. And because you have not practiced in Australia, because you are not familiar with Australian brands, if you are not sure what that medication is, feel free to ask. Feel free to ask what it is. And generally they will tell you, because when I did my exams, in one of the cases, the role player told me what the medication was. They just told me the brand name. I was not sure what that was. I asked them, what is that? And then they told me what it is. Because although these are role players, although these are patients, these are role players. They have been told how to answer certain questions in case you are confused. So in the real practice as well, if they tell you a brand name, but you are not sure what medication it is, you can always look up in the reference and find out what it is. That's why if you are asking a valid question, they will give you the answer. And allergies. Always ask about allergies. If you are prescribing for the first time, you always have to know what allergies the patient has. You can't give them the medications they are allergic to. That's why this is a routine question that you should be asking in all the cases. After the past medical history, the next thing would be the family history and psychosocial history. Again, in the psychosocial and family history, I use a structured approach that we call SADMA and SADMA chart. If you're not familiar, I suggest that you go through the history taking video one more time where I have discussed this in detail. I'll not go through that. In my case here, in the psychosocial history, important things that I want to know about are, at least I want to know about smoking and alcohol habits, because both of them can complicate or can make the problem of reflux worse. Not just that, I want to know about the typical diet. I know that hot, spicy, oily diet can cause reflux in some people, and some people are sensitive to some typical type of food. I mean, they know which food causes reflux for them. Some people might say that whenever I take something containing wheat, then I get the reflux. So ask them about those things. Occupation and stress levels can help us identify any stressors that can increase the acid secretions and can increase the problem. Family history, we can ask, there is nothing directly relevant here, but you can ask like if there is any kind of illnesses running in the family, or you can, if you want to be more specific, you can ask if there is a history of stomach or esophageal problems in their family. So that will be the family and the psychosocial history. By now, we have asked almost all the relevant questions. In our exams, when we do these cases, we get around 5 to 6 minutes for the history taking. And after the history taking, they generally will ask us about the examination. What examination would you want to do in this patient? Now, you do not have to go into the details of each step of the examination and each examination procedure, but you should be able to mention the headings of the different examinations you would want to do in the patient. Especially focus on the ones where you might get something positive for the perceived diagnosis or the provisional diagnosis you have in your mind. Don't try to do everything, because in general practice, we never do that. We never have time to do all the routine comprehensive examination checking for everything. We usually go for the focused examination depending on the patient's symptoms. So in the examination part as well, we have discussed this multiple times in the previous sessions as well. We have 3 steps of examination for the presentation in the PESCI. The first part is the routine part, where you tell the panel that you are going to do the examination, and for this examination you'll tell the patient what you are going to do. You will explain them about the procedure, you will tell them about the purpose of the examination, you will get their consent, and you'll offer chaperone as needed. That is the first part. The second part of the examination is you always comment on patient's general examination, or the general appearance and vital signs, and then other relevant things. And then you go to the relevant local and systemic examination. So the 3 steps are: first, inform the patient; second, comment on their general appearance and vitals; third, do the relevant local and systemic examination. So in this case, for example, I might start by first talking about the patient's appearance. I might check patient's appearance. I might check for the pallor in the patients. Generally, in the general examinations, we look for 7 different things. We look for pallor, icterus, lymphadenopathy, pallor, icterus, sinuses, lymphadenopathy, edema, dehydration. So these are the things we look for. And if I find any clubbing as well, if I find any of them relevant, I'll just mention that. In this case, perhaps I would comment on pallor. Reason is, if the patient has been bleeding for a long time, if the patient has any ulcers, duodenal or gastric ulcers, then they may have been bleeding for a long time. They may have anemia and they might look pale. That's why I will comment on that. And any signs of distress. Generally, signs of distress is a common thing that we try to note in all the patients. Now, the vital signs we always check regardless. And then the last thing you can mention here is BMI. Why it is important? We know that with the reflux tends to be worse in obese patients, especially when they lie down. The stomach content, the content of the tummy pushes against the stomach sphincter, gastroesophageal sphincter, because of which they are more likely to have the reflux. That's why I would want to know about the BMI of the patient. So I'm only talking about the relevant things. Then the next thing I would want to do in this case would be the head and neck examination. Now again, I don't want to do everything. I'll just check a few things. In the head and neck examination, I would just first check the oral cavity and oropharynx. Why? I want to see if there is any inflammation because of the reflux of the acid, and I want to check the teeth of the patient as well. Often in patients who have reflux, they can have the poor dentition because of the reflux. So I want to check that. Then the chest examination, I will not go into the details of chest examination, but if the patient has complaint of chest pain, I might just quickly do the auscultation to check if there is any wheezing, because in reflux sometimes there can be wheezing. So I want to check that. Then the abdominal examinations, again, I'll be very brief and specific in the abdominal examination. I'll check if there is any distension, any visible mass or scars. Then I'll palpate all the 4 quadrants where I'll be checking for any tenderness, masses, or organomegaly. But my special attention will be to the epigastric regions, because this is where they tend to have more tenderness in cases of the reflux. And I'll check for the rebound tenderness or guarding, because I want to see if there is any perforation. In case of duodenal perforation, the patient may have rebound tenderness or guarding, something that I don't want to miss. So I'll do that as well. So you can see that our examination here is quite specific. We are not going through everything, but we are trying to make sure that we are not missing anything important as well. Now, after this, the next thing is talking about the diagnosis and differential. Now, to talk about the diagnosis and differential diagnosis, you need to have a good understanding of the possible differentials, how they present, what kind of findings you expect in the examination, what investigations you need to do, and how you're going to treat the patient. Generally, after this step, the panel will ask you, so what is your diagnosis in this case, and what are your differentials? So you need to know what are the possible differentials. At least you need to know 3 or 4, as I said. What you have to be careful about is sometimes you may have a vague differential which might be, in some way related to the patient's condition, but this is something which neither you know clearly nor is very common. Never mention the differential that you do not know about, because then you'll be in trouble. Most often what the panels do is, if you talk about any, uncommon condition as one of the differentials, they will start asking you a question about that. As an example, in this case, for example, let's say that you say that I think it could be Zollinger-Ellison syndrome, then they are very likely to ask you about Zollinger-Ellison now. Or if you say that this is some kind of just let's say maltoma or some kind of the lymphatic tumors, then they are more likely to ask about those things. They want you to focus more on the common conditions that we get in the community. They don't want you to miss any serious conditions. They want you to know about the common conditions. But if you do not know about any uncommon condition or any complex conditions, that's fine, because they know that you're starting at level 1, you will have the supervisor, you are going to be in the training for a long time, so they don't mind that. But any candidate who for some reason unknowingly mentions a very uncommon differential, or just wants to show off and then talks about something which is very complex, they will definitely fall into the trap. And then after that, the rest of the questions will be about that. So be careful about what you mention in the differentials. Don't mention things just to increase your list. Okay, now what are the common conditions we have been getting in the exam so far? Let's talk about that. So up to now, whatever is the condition, your history taking, your examination will be similar. But after this, what you do depends on what your possible diagnosis is based on the positive points. So let's talk about that. The common one that we have been getting in the exam is GERD. It has been a very common one. So in case of GERD, the clinical features we get in the patient is like they will have the regurgitation, they can have chest pain, they can have dysphagia, chronic cough, and laryngitis. That means they may say that they have hoarseness. Examination findings. Examination itself may not give us much information unless we have been to the investigation and we have done the endoscopy. Otherwise, some non-specific findings we might get are the ones that I talked about, like inflammation inside the oral mucosa, maybe poor dentition, maybe some wheezing in the chest, and maybe some epigastric tenderness. But these are non-specific findings, not so helpful unless we do the investigation. In the investigations, we can do endoscopy if we have any concerns about the ongoing problem for a long time, especially if we have the patient who has odynophagia, dysphagia, who is an old patient, chronic smoker. That means if there are red flags, we can do this. Esophageal pH monitoring can give us information, but this is not very commonly done. Barium swallow can tell us about any kind of strictures, but again, not very commonly done. So these are the investigations which we can do, but don't talk about them in the exam as the first thing you would do, because in general practice, this is not the first thing you are going to do. We'll talk about the investigations that we should do in this case just in a minute once we go through this table. Treatment is very simple for GERD. It's just the PPI, or if you think that this is happening because of the hernia, hiatal hernia, or because of the sphincter problem, then we have got the surgical options as well. But we'll not go into that much detail for now. Now, the other option, the other differential we get is peptic ulcer disease. Here, the symptoms are very much similar, but they may not have any regurgitation. They usually have the epigastric pain in these cases, which can be the hunger pain or which can be the pain that get after eating the food, depending on whether it's a stomach ulcer or duodenal ulcer. Examination findings, again, are not very much specific. Most often in the peptic ulcer disease, you end up doing the H. pylori test and I will be talking about this in detail. And endoscopy is the most accurate one to make the diagnosis. But again, that is the next best thing that we'll be doing after doing some basic test. Is eosinophilic esophagitis. In this case, this is often associated with other allergic conditions like asthma or allergic rhinitis or atopic dermatitis. There are some rings, there are some furrows, there is a trachealization and a stricture presence. Again, the treatment is very similar. What we have to do in this case is we have to do the endoscopic biopsy, and then we have to look it under the microscope. And if there are 15 eosinophils per high power fill, then we make the diagnosis of eosinophilic esophagitis. Again, the diagnosis is made by the histological sample in this case. Functional dyspepsia is also very common, and most commonly in functional dyspepsia, patients have bloating and early satiety. So these are some of the things that you will get, and postprandial fullness as well. Sometimes there can be the other underlying cause which may present in this manner. Then in that case, we don't call that functional dyspepsia. That is actually the complication of those conditions. For example, let's say a patient with diabetes comes with these kind of symptoms, then it is more, we call that gastric paresis. But if we cannot attribute that symptom to anything else, then we call that functional dyspepsia. That's why it's a diagnosis of exclusion. As long as there is a reason for why it is happening, you cannot call it functional dyspepsia. So this is the last diagnosis that I would be making if I cannot find anything. And the treatment is generally PPI as the first line in all of these conditions. But in functional dyspepsia, you can try tricyclic antidepressants. Esophageal motility disorders. Here we have got usually the patient has the dysphagia, and that dysphagia will be towards the liquid more than to the solid. That is the strongest clue for this, because generally when it is happening because of the structural changes, it happens with the solid first and then happens with the liquid. But in esophageal motility disorders, the interesting thing is it's predominantly to the liquid food. Now, how we diagnose it is like, again, from the examination itself, we cannot make the diagnosis. We have to go for either the endoscopic examination, or we have to go for the high resolution manometry. The treatment for this is the calcium channel blocker, which will help in the relaxation of the sphincter or the relaxation of the smooth muscles there. We have the options of nitrates and botulinum toxin as well. But now, having talked about all of these things, the important things that I want to mention here is most often the exam cases have been these two. So I would spend my time learning how to identify these conditions, how to do the investigations, and how to manage them. These three, I will just mention in case they ask me a few other questions when I include them in the differential. But I will not spend my time learning about them because they are less common compared to the first two. Okay, now the next thing they have asked in the exam is what investigations would you want to do in this case? So in this case, I have some routine investigations that I will be doing. Here, for example, I'll be doing the full blood examination. I'll be doing the ESR, CRP, UEC, liver function test. These are the common ones that we do in almost all the cases. Celiac serology, because as I said that some of the people who have these refluxes, they say that they are sensitive to wheat. And that is one of the things that happens in the celiac as well. So you might as well do the celiac serology in this case. But the more important test to do here will be the H. pylori testing. Now, H. pylori testing is a microbiological test, and there are three different ways you can do the H. pylori testing. You can do the H. pylori testing by doing the stool test, where you check for the H. pylori antigen in the stool of the patient who has these symptoms. You can do the urea breath test, or you can do the serology. Out of these three, this is the most commonly done, and this is the most sensitive and specific test. The second most sensitive and specific would be H. pylori stool antigen testing, and serology is the last one. Serology perhaps will be more suitable for children, for example, where you may not be able to instruct them to do the urea breath test in the right way, or you may not be able to get the stool sample. Serology has some limitations. The limitation here is if the patient has had H. pylori infection once, their serology will always be positive. So that is the limitation. So we cannot use serology as post-treatment test. Like I have already treated the patient and I want to check if we have eradicated H. pylori or not. And if I want to do the test, I have to do either the stool antigen test or the urea blood test. I can't do serology because I would not be able to say whether the serology is positive because the patient still has H. pylori or it is because of the earlier response of the immune system to H. pylori. Now the diagnostic test. When can we do the diagnostic test? When can we do these 3 tests? As I have already given you a brief idea about when we do this test. Urea blood test or stool antigen test or serology. This test we generally do when we are trying to establish that the patient has H. pylori. Why it is important? Now, if the patient has H. pylori and we do not eradicate, the chances of relapse are very high, and also the chances of the gastric malignancies is also high in patients who have H. pylori. H. pylori is one of those conditions where a bacteria can cause malignancy. That's why in such cases, to identify those conditions, we do the urea blood test. Some important things that you need to know for the exam is anyone who wants to do urea blood test has to make sure that they have not taken any PPI in the last 4 weeks. If they have taken the PPI in the last 4 weeks, then we might get false negative result. So it's very important to tell the patient that they should stop taking PPI. Now the practical problem is patient might say that, but I can't tolerate. Without PPIs, my symptoms are very bad, so I can't do that. So what can you suggest them to do? For the time being, you can give them the H2 receptor antagonist or they can take antacids as needed. So antacids and H2 receptor antagonist can be continued, but they cannot take the PPIs at least 4 weeks prior to doing the test. Another important thing, practically important more than for the exam, is there can be out-of-pocket expense in urea blood test and the patient has to know. Generally, this kind of things the labs tell the patient anyway. When they go to the pathology to do the test, people there will tell them that, okay, you have to pay this much amount of money for this test. So not something for us to worry about, but something good to know for the practical purpose. The reason for that is stool antigen test, I told you, is not as sensitive and specific as the urea blood test, but for some of the reasons for which patients may do this is like this is less expensive. This is one of the options for children as well, if you can collect the stool. And the important thing of the urea blood test apply here as well. Like you have to stop PPIs at least 4 weeks prior, and patients can continue with the H2 receptor antagonist and antacids. The other one, as I already told you, serology, we will be checking for IgG. Now we know that once you have the IgG, then that stays positive for lifelong. So it's not a good test, or not a good test for 2 conditions. First, if you want to check eradication, it's not a good test. It's also not a good test for diagnosis, especially in someone who already had H. pylori, who was diagnosed as H. pylori in the past, because it cannot tell us whether this is positive because of the infection now or the infection in the past. Okay, so how are we going to treat this patient? The patient is treated there are 2 possible ways of treating the patient here. The first one is called the triple therapy. In this triple therapy, we have amoxicillin, clarithromycin, and proton pump inhibitors. Generally, this is given to the patient for 1 week. This comes in a pack, a blister pack, also called the helico pack. In this pack, what happens is all 3 medications come in the same package, and many patients find it more comfortable to take because they don't have to remember which one to take and how many to take. So this is the best option for those patients who can take it. It's also less expensive compared to buying these medications separately. If you want to buy amoxicillin, clarithromycin, proton pump inhibitors separately, it will be quite expensive for the patients. But if they buy the pack, it's less expensive. I think they pay only around $30 for the 7 days pack. Now, some patients can be sensitive to amoxicillin, for example. In the exam cases, sometimes to complicate it, they might ask you like, oh, okay, what will you do if the patient is sensitive to penicillin or has had hypersensitivity reaction to penicillin? The option is to replace amoxicillin with metronidazole. But the issue is, once you replace amoxicillin with metronidazole, there is no option for getting a pack. They have to buy each medicine separately. So it becomes a bit expensive for them. Always in your exam, make a habit of talking about the non-pharmacological management as well. Of course, you need to know the pharmacological management, but being a general practitioner, you need to tell the patient about the non-pharmacological management as well. We often talk about a SNAP-T. What is a SNAP-T? As you find relevant, talk about smoking, nutrition, alcohol, physical activity, and tranquility. And think which one of these would be relevant in your case. And often, almost in all cases, all of them will be relevant. It's always appropriate to tell the patient to quit smoking if they smoke. It's always appropriate to tell them to eat healthy and limit the alcohol intake, be physically active, and reduce the stress. That's why if you remember this, it will be easier for you to talk about the management. You will have something to talk about. Ancillary services. As a general practitioner, you may often have to take help of the other health professionals as well. These can be the specialist. This can be the other allied health professionals. Try to think who would be the best person to help the patient in addition to you. Or do you think you are able to manage the patient's condition yourself, or the patient needs to see someone else? Most of the times, the people you'll think about when you talk about the ancillary services could be the dietitian, could be the exercise physiologist, physiotherapist, occupational therapist, this kind of people. So in this case, who do you think would be suitable person? So let's say that my patient is obese, then I can consider sending the patient to the dietitian or to the exercise physiologist. Let's say that my patient has some red flag symptoms and severe symptoms. I might consider sending them to gastroenterologist for endoscopy. Or let's say that I've already tried the treatment and the patient still has the symptoms. Then in that case, I might send the patient for the endoscopy to find out what is going on there. Now, follow up. When do you want to call the patient back? In general practice, when you are sending the patient home, always tell them whether you want to see them again or not. If you want to see them, when do you want to see them? A common question that we often think about, or I often get from people, is like, so when should I call them back? Think about it. Is it urgent for you to see the patient immediately? Do you want to see the patient in 24 hours, 48 hours, or 72 hours? If that is the case, then you will be calling more immediately. Generally, when I'm reviewing children and they are very sick, I want to call, and if I'm not sending them to emergency, I call them back in 24 hours. If they are children, not so sick, I think mild to moderate sickness, then in that case, I call them back in 48 hours. Adults with mild to moderate symptoms, I call them in 72 hours. Adults with severe symptoms, I call them back in 48 hours. Is this a guideline? No, this is just my way of doing things. So as long as you have a rational, you might as well do the same thing. What about the others? Generally, I call them back to assess whether they are doing well or not. So some of the pointers that I use is after completing the treatment, for example, if I have given them treatment, I call them back after completing the treatment. If I'm planning to give them another script, then I call them back like, okay, I'm giving you for 7 days. I want you to come back. I'll review and I'll give you another script for, let's say, another 7 days. I might call them back in a week. If I'm just assessing some of the investigations and I want to check if their situation has changed or not, then I think about the physiology, like when it is likely to get better. As an example, if I'm checking someone for thyroid, I might call them back after 4 to 6 weeks. If I'm checking for cholesterol, I might call them back after 6 weeks. If I'm checking for, let's say, SbA1c level, I'll call them back after 3 months, and so on. So these are based on the physiology. So in this case, we'll be calling this person back after around 4 to 8 weeks to check if we have eradicated or not, because some patients may need more than once this triple therapy. So urea breath test can be done after 4 to 8 weeks, but you have to tell the patient that during that time they should first abstain from taking the PPIs for at least 4 weeks. I have written 2 weeks there, it should be 4 weeks. And then I can also call them back. I can also tell them about the red flags. I can think about the referral if needed, and keep them reading materials. Always think about reading materials in the real practice as well. Give them something to read so that they know about what is happening. So this is a comprehensive approach to someone who is presenting with the heartburn and how to present it in the exam. Now, let's do a bit of a question answer. If anyone has any question, please feel free to unmute themselves and ask the question. If no one has any questions, I'll just simply move on to the next case. Looks like we don't have any questions here, so I'm starting the next case then. Okay, I guess we are good. Let's just start the next question then. So our next case is 49-year-old lady with a skin lesion on chest. And they have asked us to do the history, differential diagnosis, investigation, diagnosis, and management. So how would we do this? In these cases, one of the things you have to remember is often the panel will ask you to do the examination of the lesion, and they will show you a photo as well, and they'll ask you, okay, just tell us what you see in the photo. So what you have to do in that case is you have to learn how to do the examination of a rash in the exam, or examination of a skin lesion in the exam. How to do it by using the approach of inspection and palpation. In the inspection, primary and secondary morphology. In the palpation, what are the important things we need to palpate? So you need to have a structured approach, because some of the times what happens is like they show you a picture and you look at it and you say, oh, this is tinea. If you say that, you'll fail the exam, because that's not what they're asking. They're asking you, what do you see there, before calling it tinea. So what they are expecting from you is, because I see these features, that's why I think this is tinea, based on these clinical features, based on what I have identified. A common mistake that people often make, maybe because of the nervousness of the exam. Now again, asking the questions, we do it in the same way. Some of the questions may be relevant, some of the questions may not be relevant, while asking using the Socrates format. Here also, I will do the same thing. Where exactly is the skin lesion? So the patient might already have told me this information. In that case, I'll skip that. If not, I'll just ask, where is it? And when did you first notice the lesion? And can you describe what it looks like, that with the character of the lesion? And radiation in case of skin lesions would be more about the distribution, like has the lesion spread to other places? Did it start from one place and stayed there, or it has spread to other places as well? Then associated symptoms, often we want to know about, in case of any skin rashes, we want to know about itching, pain, bleeding, or changes in the shape, color, size of the lesion. Timing is, does it come and go? There are some evanescent rash which come and go, and some which stay there all the time. Exacerbating and relieving factors, what makes it better or worse, and severity. Again, in the case of severity, it's, I think, more appropriate to ask the patient, like, how is it affecting you, rather than asking on a scale of 1 to 10 here. After this, you can go on to ask about the differentials, which will depend on what you see in the picture, because I have not shown you the picture, so I'm moving on to the next point, which is past medical history. So past medical history, I would want to know if the patient has any history of the skin conditions. Some of the conditions like psoriasis may come and go, and so if you ask, they might be able to tell you that, yeah, I often get this rash, usually during this time of the year. So that will give you the clue. Now, in our exam case, the patient actually says that they do not have any history of any similar skin lesions in the past, but yes, they have diabetes and hypertension. Now, what often happens in the exam is, like, when they say diabetes and hypertension, sometimes we get too distracted by this. We start thinking, like, what is the relation between diabetes and hypertension? What you should not forget is, in general practice, you will often get patients with chronic conditions, which every now and then may have some other acute conditions as well. A patient with diabetes might also have a flu. So if I get someone with the flu symptoms and have diabetes, I don't need to think like, could it be related to the diabetes? Could it be the complication? So that's something for us to consider. Not all the time the background conditions may match with the presenting complaint of the patient, and that's fine. Maybe that's just something patient always had. Just use your clinical judgment in making this decision. Past surgical history, here, in terms of surgery, what I want to know is if they had any skin lesions removed in the past. In Australia, it is very common for people to have SCC, BCC removed from their bodies, or even melanoma. That's why if you ask them, like, have you had any skin lesions removed, they might tell you. If you just ask them, have you had any surgeries, they will say no, because they don't consider this as a surgery. But if you specifically ask them, Have you had any skin lesions removed? Have you had any kind of skin tags or anything removed from your skin, from your body? They might say, oh yeah, I had a basal cell carcinoma, I had a BCC, which was removed. Many of them understand what BCC, SCC, and melanoma are. Although they may not understand the difference between them, but they understand, they have heard these terms like BCC, SCC, and melanoma simply for the reason that they are very common in Australia. And medications. You can ask them like, have they used anything for their rash? And you can also ask if they are taking any other medications, because sometimes the medications can cause rash as well. So we want to know. Sometimes if these are allergic rash, then also we need to ask about the medications they are taking. Allergies, of course, are important for someone presenting with rash. Family history, directly not much important, but still you can ask about the family history of any skin cancer or other types of cancer in this case. Even though you are not thinking about cancer, always ask about the family history of skin cancer and skin conditions, because they tend to run in the family. Someone who has the family history of skin cancer is at a higher risk of having the malignancies as compared to someone who never has had it in the family. Smoking, alcohol, diet, these are the routine psychosocial questions which we can ask here. Some of them are related to the conditions, some of them are not, but it's up to you to decide which ones you want to ask, and how much time you have left will also determine how many questions you can ask. One thing that I would perhaps ask here in SADMA, in addition to all these questions, I mean, if I don't have time to ask all these questions, if I have to decide and pick 2 questions, let's say, then I would ask about the occupation, because it can tell me about the occupation exposure. And I would ask about the travel, because it might give me some contact history or exposure history. As an example, one of my patients had rash on his hand, which he was trying to get rid of for a long time. He had been to many doctors. And one simple question I had asked him was like, what is your occupation? And he said that he's a bricklayer. And I asked him like, so do you have to deal with the concretes and bricks all the time? Yes. Do we use any gloves? No. So could it be related to your exposure to the concrete? And he was like, I'm not sure. And I asked like, can you try wearing the gloves for some time? And he was like, I'm not sure if I'm allowed to. I said, that is a personal protective equipment, so you should try it and let's see how it goes. In the interim, just use this steroid cream. He did that for 2-3 weeks. He came back and said, yeah, I think I was allergic. But his confusion was, but I was a bricklayer for a long time. I have been doing this for a long time. So how can I suddenly be allergic to this? And this is not uncommon, by the way. Someone might be using concrete for a long time and might be allergic. Suddenly might be allergic. It's not uncommon. That can be a confounder for some of us. Like if they have been using the concrete for a long time, then it's not possible. But think about this. Some of the contact dermatitis can happen even after the patient has left the job. Like I have heard the stories, and I have read the case series where one of the patient was doing this something related to rubber for a long time, and then left the job. Maybe after 5-10 years of leaving the job, became allergic to the same thing. So it's possible. So ask about that. Now, in terms of stress, stress directly may not be contributing to the rash, but I would want to know how much stress the rash is actually creating to the patient. Some of the things which are visible to others can be quite distressing to people. They might find a bit embarrassing. One of the reasons people come to you when they have rash on the hands more quickly than when they have rash on the body is because hands, they are visible. And compare that with the face. If it is on the face, they will immediately come. If it's on the hands, maybe after a few days. If it's on the body, they will take their time. So stress level is really important thing for us to assess in patients. Ask them like, how distressing has it been for you because of this? Now, in the physical examination, general things, I will not repeat. You always start in the same way. You do the routine things about explaining to the patient purpose, chaperone, all those things. But after that, you will be asked to do the examination of the rash. They will show you a picture and then ask you, okay, now describe this rash. Or what do you see? Something like that. Be systematic. This part I'm skipping. Be systematic. Go through the primary and secondary characteristics of the rash. Primary characteristics of the rash. What are the things you should be talking about? Size. Try to tell in millimeters how big the rash looks like, or in centimeters as well, but usually millimeters will be more relevant as we usually get small rashes. So try to tell how big the rash is. And second is shape. How does the rash look like? Is it round, oval, irregular? What does it look like? Then the next thing you would want to talk about is the color. What do you see there? Brown, black, red, flesh colored, what is it? Distribution. How many of those lesions you see? Single lesion, multiple lesions. Arrangement, like are they in any pattern? Linear, grouped, scattered. Do you see any kind of shape there? Secondary characteristics. Secondary characteristics usually are the other attributes of the rash. For example, the surface. Does it look smooth, rough, verrucous, scaly? Border, well-defined or ill-defined, regular or irregular. Elevation, flat, raised, depressed. Presence of any crust, scale or ulceration. And then any visible blood vessels or pigment network. Now, why do we need to learn it this way? Because when we look at different kinds of rashes and we think about their underlying characteristics, these are the features which will help us in making the diagnosis. So I'll show you a big table where I'll be showing you some of the possible differentials in case of this lady. So if I know what these differentials feel like, look like when I do the examination, I can make the diagnosis more easily. So from the practical purpose as well, if you think in terms of primary, secondary characteristics, and then what you feel in the palpation, it will be easier for you to identify the rash. So in the palpation, what are the things you look for? You look for texture, how it feels, whether it is smooth, rough, firm, or soft. Consistency, whether it is hard, soft, fluctuate, or form. Mobility, whether it is tethered to the underlying structure or freely mobile. Any localized rise in temperature or the rise in temperature of the surrounding skin. Tenderness, whether it is tender on palpation or not. And depth, if you feel, do you feel like it is going up to the dermis or up to the subcutaneous tissue? So that you will try to check in the palpation. Then why do we do this? Because of these regions. So I am showing you here some of the different kind of rashes and how they, what their primary characteristics are, what their secondary characteristics are, and how they feel when you touch them. And in the exam, if you make a habit of presenting in this way, you'll be able to make the diagnosis more easily as well. A common exam case is seborrheic keratosis. So if we think about the primary characteristics of seborrheic keratosis, its size is usually 1 millimeter to 6 centimeter. Shape is round or oval. Color is usually yellow-brown or dark brown. Distribution is multiple lesions are very common. Arrangement is they are usually scattered. They are not in groups. Secondary characteristics is their surface looks waxy or velvety or warty. Border is sharply demarcated. Elevation is they are raised from the surrounding skin. You might be able to see some kind of crust or scale. Sometimes they may become irritated and bleed as well. Any visible blood vessels or pigment network? No. You usually do not see them in seborrheic keratosis. Texture. It may feel greasy, waxy, or velvety. Consistency is soft. It's freely mobile. Temperature is normal. And tenderness occasionally pruritic but not usually painful. Depth, it's limited to the epidermis. You will not be able to feel it deep down. So you can see that when you do the examination, you get these features, then you can make the diagnosis of seborrheic keratosis. How it happens in the exam? You just mentioned that I'm going to check this in the primary morphology, this in the secondary morphology, and this in the palpation, and then the panel tells you, okay, primary morphology, the rash is like this, secondary like this, palpation, these are the features. And then based on that, you have to say, oh, okay, then I think it's seborrheic keratosis. I've seen the picture. These are the features you have told me. So based on that, I think this is seborrheic keratosis. That is the reason why you should be presenting in this manner, a systemic structured presentation. Let's go through a few here. I'll try to be a bit quick so that we can do the third case as well. The second one is actinic keratosis. Actinic keratosis size, generally they are of different sizes. Then shape, usually they are irregular. If you compare this with the seborrheic now, you know that one is quite circular and well demarcated border. This one is irregular. Color is usually they have erythematous base. They can be single or multiple, and they are scattered. If you feel them, they feel like sand, or they feel quite rough, and they usually have scales. They do not have well demarcated border. Sometimes they can be slightly raised, but most of the times they are flat. They can be crust, scalar ulceration, and you will see the sign of hyperkeratosis as it is in the name itself, and you will not see any blood vessels. Now, regarding the palpation features, texture is rough or firm. Consistency is firm. Mobility, usually they are fixed to the underlying structures. Temperature is normal. Tenderness, sometimes they can be tender to touch, and depth, they may go up to the dermis. Basal cell carcinoma, a very common condition that we get in the exam. What I'm going to do now is I'll just show you the slide. When you will be reviewing these slides later, you can just pause the slide and read these features so that you can make your own notes and then go through that. By the way, if you are enrolled in the course, you know that the notes will be available just below the slides. I mean, below the video. So you can be, you can read through these things all by yourself as well. Just a heads up here. Sorry. This video will be available on YouTube. So you'll be able to watch, but it will disappear after a week. People who are enrolled in the course will be able to watch it as long as they want. So these are the features of squamous cell carcinoma. Just pause the video, read through them, make sure that you understand the differences between this and the others, and that will help you in the exam in making the diagnosis, but more importantly, it will help you in the day-to-day practice as well. These are based on my own notes, and they have been extremely helpful for me, and I hope it will be the same for you as well. Melanoma, these are the features. Some of the important things in melanoma is you will see the visible, sometimes you'll see the visible blood vessels or the pigment network. The other condition where you see the visible blood vessel is basal cell carcinoma as well, where you might see the telangiectasia, very commonly seen. Dermatofibroma, they are fleshy. Generally, they don't have any blood vessels or the pigment network. And the characteristic finding you find is the central dimple. If you pinch, there will be a central dimple. So this is their characteristic finding. The other thing is, if you think it's a case of melanoma, you have to talk about this ABCDE criteria as well, which has been used for a very long time now, and there is a very good sensitivity of this criteria. Any lesion which looks asymmetrical, not in just in shape and color, not just in shape but also in color, and border irregularity, which has the variation of color. In one side it looks different as compared to the other side, which is large in diameter, like more than 6 millimeter, and which is changing over time. These are called these are likely to be melanoma. So what investigations do you do in skin lesions? Mention dermoscopy, but be careful because dermoscopy is not that easy for the beginners. So what you say is, we can do the dermoscopy in this case, but since I'm not confident in doing the dermoscopy, I would like to get the help of my supervisor. That's what you can say, and it's an acceptable answer because nobody is expecting you to be an expert in dermoscopy. Even the experts can get confused. But you have to remember that any skin lesions that you think you need to examine, you have to do the dermoscopy as part of the initial investigations. Now, regarding the biopsy, we have the option of shape biopsy, punch biopsy, excision biopsy. Confusion we often have that I have seen among people is, should I do punch biopsy? Should I do shape biopsy? Should I do excision biopsy? Generally, how I think about these things is, can I do excision biopsy? I always start from the excision biopsy because the best way to get the histological architecture of any tissue is to get the excision, get the tissue completely, send it to the lab so that the pathologist can go through it and see how it looks like. If you get the complete lesion, it's always easier for them to make the diagnosis. Otherwise, any other kind of biopsy may not get the complete structure. So my preference would be to think, can I do the excision biopsy? If yes, I'll go ahead with that. If I can't do excision biopsy for some reason, then I'll think about the shape biopsy or punch biopsy. Now, punch biopsy sometimes can be done as an excision biopsy as well, especially let's say there is a tiny lesion and I have a punch of let's say 6 millimeter or above, and I can get the complete lesion along with a border of around 4 mm, then I might as well do the punch biopsy because it will be fast for me. I can get the good amount of tissue without doing the excision biopsy. So if you can be a bit creative and then can take the whole tissue like that, I think you can do it, because at the end of the day, what we want is we want to get the whole architecture of the tissue so that we can see how is the penetration, what is the depth of the skin condition we are looking at, especially because in case of melanoma, how much margin you need to take depends on what is the depth. That's why we always have to make sure that we have adequate depth. So you can do the and you have the adequate margin. That's why we have to make sure that we get as much of the tissue as we possibly and practically can. Now, in our exam case, this was a seborrheic keratosis. Once we mentioned that we would want to do the biopsy, the panel said that, okay, the biopsy has returned as seborrheic keratosis. What are you going to do? Or how are you going to manage the patient? It's very simple now. Seborrheic keratosis is a benign condition because it does not transform into any malignant lesions, and it's very common, especially in the elderly population. And the most important thing for the patient is you have to tell them that it's not cancer. It's not cancer and it does not become cancer. What is the treatment? You can just leave it. If it's not bothering the patient, it's better to leave it just like that. But in our case, we have already done the biopsy. So if we have taken out the whole lesion, that's fine. In one of the cases, for example, one of my patients was concerned that this was melanoma. And I was sure that this was seborrheic keratosis, but the patient was like, I told the patient multiple times that this is seborrheic keratosis, but she was adamant that I took it out. She just didn't want it there. So I took it out and came back as seborrheic keratosis. The lesion was already gone. Patient was happy. So fine. If the patient or if you tell the patient just based on the clinical appearance that this is seborrheic keratosis and they're happy, you may not even reach the stage of thinking about what to do. But if let's say that the patient has already had the excision biopsy and then it has come back as seborrheic keratosis, then also it's fine. But in other conditions, let's say that patient says that, okay, yeah, I'm okay with the seborrheic keratosis diagnosis, but can you do something about it? Can you do anything here? The most commonly done thing in the general practice would be cryotherapy. You can just freeze the lesion, give the patient 2 weeks time, ask them to come back after 2 weeks, look at it. Most likely it will get inflamed and fall off. You have to tell the patient whenever you are doing the cryo that your lesion will get a bit worse before it gets better. Otherwise, they will say that the doctor treated and made it even worse. It was not like this before. So you have to say that. The other option is curettage and electrosurgery. Most of the clinics do not have this. So if you want to mention, you can. In the exam, it's in the interview, it is better to tell them that in our clinic, this is what we do. Because this shows to the panel that you have been to the clinic, you are familiar with the working environment, you are familiar with the facilities available there, rather than just listing the options. On non-pharmacological SNAP-T, you can talk here as well. As I told you that in almost all the cases, you can talk about that. Monitoring, you can ask the patient to, if you have done the biopsy, you can ask the patient to come back for the suture removal or when there is any change, and you tell the patient about the red flags. Like if you see any of these changes like rapid growth, bleeding, pain, new lesions, just come back and then we'll look into that as well. Now, dermoscopy is something they expect us to know. I had some pictures here, but for some reason it is saying error. Anyway, maybe we'll skip that for now. They do not ask you what are the dermoscopic features, and perhaps it's not that much important for the PESCI itself, but this is something I created for myself so that when I would do dermoscopy, I would be able to identify the lesions. Those of you who are interested in this for the future, you can again pause the video, look at these features. This is quite helpful. The images I had here was from DermNet, and many of you perhaps are already familiar with DermNet. DermNet has a course for dermoscopy as well, so you can go through that course. They have a beautiful atlas there which shows you different features, dermoscopic features of different lesions. Now, what I say is always start with the basal cell carcinoma, squamous cell carcinoma, and melanoma, because you don't want to miss these three. The others, even if you miss, you'll have the opportunity. But if you miss these three, it can be terrible for the patient and for you as well, medical legally. So go through that. But in the exam, they will not ask you mostly about these things. Just for your future practice, if you want to go through these notes, I think it will be quite helpful. Now, patient education, referral, reading materials, that is the part of management in almost all the cases. So in all cases, at the end, you tell the patient, these are the red flags. If this happens, come back to me immediately. Patient education, these are a few things for you to read. Please read, and if you have any questions, you can ask me. Think about referral. Does this patient require any referral? I will not be referring any patient with seborrheic keratosis to anyone. Either I'm going to take it out myself, or I will just assure the patient that you don't need to worry about anything. It doesn't need anything, or I can just take it out for you. The only In my case, I don't take out the lesions which are near the eyes or near the sensitive structures, but otherwise I take out them without much problem anyway. So this is the case of the skin lesion on the chest, which was seborrheic keratosis. Make sure that you know how to approach any skin lesions. This is not just about seborrheic keratosis. It can be in your exam. Maybe it will be actinic keratosis. Maybe it will be basal cell carcinoma. Maybe it will be melanoma. On the website, I have a specific section where I have discussed about the basal cell carcinoma, melanoma, and squamous cell carcinoma, how to treat them, what are the treatment options, pharmacological options, cryotherapy, and the surgical options. Make sure that you know thoroughly about those three conditions because they are very common in Australia. They want every one of the GPs to know about these three conditions at least. And the others like actinic keratosis and seborrheic keratosis are also very common, so it's good to know about them as well, and I have discussed the main points anyway. Okay, any questions, anyone? I'm not sure about December. You may need to check IME or you may need to check with IME or RCGP. I don't know much about ACRM. I don't do any courses for ACRM anyway. For IME or RCGP, you need to ask, but I think they stop somewhere in the end of November. I'm not 100% sure, but I think they stop after November, end of November. Any other questions, anyone? So either I'm explaining very well or people are sleeping because nobody's asking anything. I hope this is the reason is the first one. When to involve supervisor and nurse. Whenever you have any confusion about your treatment, you have to involve your supervisor. However, remember that if you are doing the level 1, then your supervisor has to approve your management plan in each and every case. So you will not be wrong to say after saying everything, it will not be wrong for you to say that, and I will make sure that I discuss this with my supervisor. I'll get my supervisor's input because level 1 supervision means your supervisor has to be present in the clinic all the time when you are practicing. Your supervisor has to check each one of your case before the patient leaves the premise, and they are not allowed to supervise you via telephone or any other electronic means. So these are the 3 criteria for supervision in level 1, which means any case you have to ask the supervisor. Now, a common mistake about involving the supervisor is like, okay, let's say that how are you going to manage a case of, let's say, H. pylori? What treatment regimen do you use in case of H. pylori eradication? And if you say that, I'll ask my supervisor, that is not acceptable. Anytime you want to ask your supervisor, you need to know what you want to ask and what could be the possible answer. Let me give you one example. Let's say that you are confused between whether it is gastroesophageal reflux or peptic ulcer disease. And the reason you are confused is because the patient has epigastric pain, complaints of bloating and fullness, and also has minimal reflux. So now you are feeling like the symptoms are overlapping, so you're not exactly sure whether to call it reflux or peptic ulcer disease. So if you want to mention that I want to include my supervisor, what you have to say is, because my patient has the symptoms consistent with both gastric esophageal reflux as well as peptic ulcer disease, I would like to get the input of my supervisor. So that means you have to first, always, when you say supervisor, first mention what you know and then mention why you want to get your supervisor to be involved. What are you willing to get from the supervisor? Remember, the reason they have supervisor in place is not because they don't trust you. The reason they have supervisor is because they expect that from each case you learn something from your supervisor. Your supervisor is not there to do your job. Your supervisor is not there to make your diagnosis or treat your patient. Your supervisor is there because the supervisor has the experience of being in the Australian health system, and you are coming from a different health system. So when you go to your supervisor, you have your own knowledge, things that you know, and you have your own confusion. Every time you mention the word supervisor, don't say that I will ask my supervisor. Explain it like, I know this, but I am confused about this, and this is what I'm going to ask my supervisor. I hope I have explained myself well. Yes, doctor? It's once a week class. It's the difference between people who are enrolled in the course and who are not enrolled is, first difference is like if you are not enrolled, you will not have access to the recordings of the live classes. The second is people who are enrolled in the course will have access to all the recordings for the previous classes as well as the recorded lessons for each topic. And people who are not enrolled will not be able to access any of that. It's more of a self-directed learning rather than the live 2 weeks or 1 week class. And this is based on my previous experience of taking the class. So I used to take the live classes for 2 weeks continuously. I found two things. First, not all the people can take these classes continuously for 2 weeks because most of you are working as doctors in your respective countries, or even if you are in Australia, you might be doing some kind of job. Attending the class every day is sometimes practically not possible. So many doctors were using the recordings rather than attending the live classes. Yes. Yeah. And yeah. Thank you. I was just trying to explain why we changed to this model. And the second thing we found is 2 weeks were not enough. In 2 weeks, we could only cover, let's say that, because in every class, we could cover around 3 cases. And then we are doing it around 4 days a week or 5 days a week. So let's say that even if I cover 3 cases every day, 5 days I would cover 15 cases, and 2 weeks I would cover only 30 cases. And 30 cases are not enough. So what I decided after that is, okay, let's make it flexible for you and for me. For me, it's flexible that I don't have to sit for the class every day after my full-time work, which would be quite exhausting for me. For you, it would be flexible that you could go back to the topics anytime you wanted and then go through the questions. Now, what if you have confusion? 2 things you can do. In fact, 3. First is in every lesson on the sidebar, you will see a place to ask questions. If you post any questions there, it directly comes to me as an email. And when I reply to that email, it again goes back to you as an email and also stays there as answer to that question there, which means anyone in the future might be able to see those questions. Or in a way, let's say that the confusion you have could be the confusion that other person had in the past as well. So you can just have a look at that question and get your answer. That's one thing. The second place where you can ask me a question is like the groups we have. We have got the Telegram group. We have got the Facebook group. You can post questions there. I regularly monitor those posts and questions, or you can simply send me a direct message on Telegram or Facebook Messenger. So I reply to those messages as well. So that is the second way to ask questions. The third is, of course, these live classes. You can come to the live session and ask me questions. Okay, let's go through our third case of the day, 13-year-old Taylor who has come with the knee pain. And what are we going to do? Now, before I jump into this case, you have already listened to me for the last 1.5 hours. Perhaps you have already thought about what could be a possible approach to these cases. Just think about it. How would we do it? Now, I have a patient coming to me with a complaint of knee pain. What would I do in this case? Okay, this is my practice. I'm preparing for my PESCI. I'm alone. I don't have a study partner, let's say. and I'm just doing it all by myself because I'm working. I can't find a consistent study partner whose time zone matches with mine, whose shift matches with mine. So I'm just planning to prepare all by myself with the help of the videos and the class. How can I do it? What you can do is when you are watching the videos, look at the first slide or the question, pause the video. Now think yourself, okay, in this case, what I'm going to do is I'll ask Stella about the pain using Socrates. I'll ask about the red flags. In case of an adolescent patient with the knee pain, my red flags will be these 5 conditions or these 3 conditions or whatever. Then I'll ask him about the past medical history where I want to know about these things. Psychosocial history, I will do this. And this is what I'm going to ask in the family history. In the examination, these are the steps I'll go through. Investigations, I will do this. And then I will do this kind of management. Let's say the possible diagnosis is this, then my management will be like this and so on. Don't think, by the way, this is how I practice, by the way. I'm just telling you my way of how I did this. When I was preparing for PESCI, I didn't have a study partner. I had one partner, but we both were busy, and so we would hardly get any time. I think in 2 months' time, I think only two or three times we had the chance to interact with each other. Otherwise, yeah, every now and then we'd just send a message, ask questions, and that was all. How I used to practice, I would just look at the case, I would start the timer on my phone, and then I would start speaking. I would start the voice memo that you have on iPhone. I would just start that voice memo, and then I would start speaking. I would just say like, okay, this is my case. Hello panel, whatever I would do. I would just do that. Hello panel, whatever. And then I would start speaking like I have a case like this. In this case, I would start like this. I would ask questions about this. Then after that, I would inquire about the red flags. I would be asking this and this question to know about the patient's red flags. Then I would ask this in the past medical history. Then I would ask the patient about the medicine and so on. These are the questions I'll be asking in psychosocial history for this reason, and this is what I will ask in family history. So basically, I would just record myself, and then after that, after the recording would be done, I would just listen back to myself, identifying my mistakes, how many times I stammered, how many times my sentences were not good. Because at the end of the day, this is interview. This is not just about your knowledge. It's about how you present yourself. Are you a calm, controlled, and confident doctor? Or are you a hesitant, nervous doctor who lacks confidence? These things are very important in interviews, any kind of interviews. So I was deliberately looking at my sentence structures. I was deliberately listening to myself and identifying my problems with my, let's say, articulation, clarity of my pronunciation, how I was framing the questions. So that's how I prepared. So I would listen to myself, I would give myself feedback, and then make sure that I did not repeat them again. And I kept practicing like that. So my timing got better with time. My confidence got better. I felt like I was able to ask questions without thinking much. I would not have a false start. Now, false start is where you are asking patient a question, and then suddenly you realize that you can't complete that sentence in English, and then you restart the question. It shows lack of confidence. It also is not... It just kills more time. It wastes time as well. As an example, let's say that I'm asking my patient, what can I do? What brings you here today? So what I did was, what can I do? That's what I was going to ask. What can I do for you today? For some reason, I asked, what can I? And then I suddenly got nervous, or I couldn't complete the sentence. I restarted with another sentence. This tends to happen with those people who have not practiced. The benefits of role play is it gives you a lived experience. It gives you the opportunity to find out where you are going to stammer. And therefore, if you don't have a study partner, you can be your own partner, or your phone can be your partner. Record yourself, listen back to it, and identify your mistakes. And these days we have this, the AI, like you have the ChatGPT, you have this Perplexity AI, which I have mentioned in one of my videos. You have Claude. You have Google Gemini. You can use any one of them. What you can do is just prepare an answer. Just record yourself. Get the transcript of that. In the iOS 18, you can get the transcript of your recording as well. Get the transcript, paste it in one of these AI, and ask for feedback. My case is this is my approach. Where do you think I can improve? And often you'll get the feedback as well. So take help of the technology. If you can't find a teacher who can be with you all the time, use the technology which you can access all the time. Anyway, let's move ahead with this case now. So What I will ask in this case, I'll ask the Socrates. I will not go through the questions one more time. You already know, but I will tell you what were the positive points in the case. The site of the pain in this case was localized to the front of their knee. The onset was it started gradually over the past 6 months. The character of the pain was it is a dull pain, and patient had the aching sensation. The radiation patient said that no, it does not radiate anywhere. It's just there all the time. Then the red flags questions, that you need to ask in this case are any injuries or falls. Anytime the patient comes with the pain, musculoskeletal pain, the first thing we should be thinking about is, did you have any kind of injuries? Did you have any trauma? Trauma history is important. Weight loss is important in adolescent patient because we want to rule out the malignancies. So we have to ask about that skeletal malignancies. So have you experienced any unexplained weight loss? That could be a sign of an underlying medical condition. I don't need to say why. I can just ask, like, have you experienced any unexplained weight loss? And generally, in case of malignancies, I ask 4 questions. Loss of weight, loss of appetite, lumps or bumps anywhere in the body. Loss of weight, loss of appetite, lumps or bumps anywhere in the body. So there's 4 things I always ask whenever I think that could be malignancy, because these 4 symptoms are the very common symptoms of many malignancies. Night sweats and fevers. Why? Because these are the constitutional symptoms. They are present in cases of the infections. For example, a patient with HIV can have this, but a patient of lymphoma can also have this. So night sweats and fevers, I ask as red flag questions. Skin changes, any overlying skin changes, like in cases of, for example, this septic arthritis, I might see the swollen knee with the redness or erythema, overlying erythema. So I will ask that. Numbness and tingling to identify any neurological compromise, and vascular compromise, you can ask about the skin color and temperature as part of the skin changes. Change in skin color or temperature could be the underlying vascular problem. Numbness and tingling could be the underlying neurological problem. Instability and locking, this can happen when the patient has any meniscal injuries or when the patient has any loose lying cartilage, which we call osteochondritis dissecans. So we can ask them, like, have you had or locks up? What that indicates? That indicates mechanical issue. The common differentials we have in this case are the patellofemoral pain, mechanical issues, patellar instability, and growth or masses. So the questions I can ask for these differentials are, do you feel pain behind your kneecap when sitting for long periods? Now, some of the common scenarios that you need to think of here are, the patient may not tell you that, yeah, I feel the pain behind the knee when I sit for a long time. What they might actually tell you is, when I go to watch movies and I try to get up, then I get pain. When I am traveling and sitting in the bus and then I try to get up, then I get the pain. Indirectly, what they are telling you is, like, when I sit for a long time with my knees flexed, then I get the pain, which is giving you the clue that this is happening because of the friction between the patella and the underlying the condyles. So that's a clue. Mechanical issues, is there any clicking or popping in your knee, or do you get any locking, or do you get any sensation of your knee giving away? Now, mechanical issues, usually if there are torn meniscus, if there are loose cartilage, as I told you earlier, there can be problems such as locking, there can be problems such as clicking. So you can ask those questions. Patellar instability, do you ever feel like your kneecap is shifting out of place? This happens in the patellar dislocation, and this tends to be a recurrent problem. That's why they might be able to tell you about that. Growth or masses, have you noticed any lumps or bumps around the knee in addition to the lumps or bumps anywhere else in the body, which by asking that question, we are asking about lymph nodes mostly, or any metastatic masses. But even in the localized lumps, and even if we get the localized lumps and bumps, that can also give us idea about the underlying growths or masses. And it can happen when they have cysts, when they have tumors, popliteal cysts, for example, when they have any tumors like the Ewing sarcoma or osteosarcoma, they can also give us this kind of presentation. Past medical history. Now, so if you remember, what we have done so far is we have asked history of presenting illness, we have asked about red flags, we have asked about the differentials. Now we'll be asking about the past medical history. Medical conditions, we can ask, like, do you have any other medical conditions we should be aware of? One tip for the exam. If you know the name of the role player, they will always tell you the name. Try to include their name every now and then. That gives you two benefits. First, it helps in building the rapport. As people always say that everyone loves their name, and hearing their names from other people is something that makes them more comfortable with them. Even when you're talking with your patient, this is something you can try as well. When you mention them by name, they feel better. This is a psychological phenomenon which has been mentioned in many sales books and many other human behavior books as well, that you mention the people by their name, you address them directly, they are more likely to communicate better. Previous injuries, have you ever had any surgeries or injuries to your knee or legs in the past? If they are taking any medications and allergies, which are the routine questions. Now, in the psychosocial history, because he is a 13-year-old, so I'm not assuming that he drinks alcohol. Perhaps he does, I don't know. But rather than focusing on smoking and alcohol, I'm focusing more on their development. So I'm asking them, like, have you noticed any recent growth spurts? Because one of the differentials in our list can be the Osgood-Schlatter disease. The other one could be the growing pains. Both of them can happen near around the growth spurts. That's why I can ask this question, like, have you noticed any recent growth spurts? Puberty timing of the parents is another thing, like when they had the puberty, because the children tend to have their puberty at the same time as their parents. So we can get an idea about if the child is entering the puberty and if this could be something related to that. If you remember, in case of epiphysitis or the Osgood-Schlatter, what happens is like there is a mismatch in the growth rate of the muscles and the bones. So the muscle starts pulling the tibial tubercle, that causes the pain. The other psychosocial history, these are more of the opportunistic screening or the impact of the disease on the patient. In case of adolescent patient, we in our history taking structure, we use head SS. Those of you who do not know what head SS is, please check the history taking for children, where I have discussed children and adolescent, where I have discussed these topics. Basically, you want to identify about home, education, activities, drugs and diets, sexuality and societality in young people. Depending on what is relevant, you can just pick the questions that you want to ask. School and stress can be important for us to ask here. May not be directly contributing to the presentation of the patient, but can be something that can help us in the management later on. Mood and sleep. Has the knee pain affected your mood or sleep in any way? Anyone with chronic conditions can have impact on their mood or then in their psychological state. So it's a good thing to ask. Let's imagine that Taylor is a football player in the school, and because of his knee pain, he has not been able to play, and he's now going to miss interstate competition. That can have a distressing impact on these adolescent patients. So asking about these things are still relevant from that perspective. So you can ask about the activity limitations and emotional impact. Lifestyles and sports. What you want to ask here is like, do you play any sports? Because the sports injuries in adolescent is very common injury. So you can ask like, do you play any sports? And in your case, in the exam case, in this particular case, this the role player say that he plays basketball 3 to 4 times per week. The reason I'm asking this is like, because I want to know whether they are using the appropriate footwear or not, whether they are using the appropriate personal protective equipment for that particular sports or not, and whether they do the warm-up activities before doing the before playing the sports. Because I know that if there is no stretching or warm-up before going into the intense play, that can cause more pain. So that's why I want to ask these questions, like, what kind of shoes do you wear? Do you wear comfortable shoes for your sports, or do you use the regular shoes? Do you do a bit of stretching and warm-ups before you start playing? Now, these questions from the medical perspective, you might feel like, but why am I asking these many questions? But these are important things in terms of the lifestyle factors that can contribute to the patient's complaint. Family history, you can ask some screening questions, nothing relevant. You might say that there are some idiopathic arthritis that can run in the family, but I wouldn't be too worried about that simply because they are not very common. But if you want to ask, you might ask about any family history of knee problems or arthritis or any conditions running in the family. But I am not too much worried about the history, family history itself. Physical examination, I have cut down the details of what I would do in the beginning, like explaining to the patient general appearance and so on, which you still have to do. I'm directly jumping into the main examination just to save some time here. We will start in the examination, we will start with inspection. What we first have to do is first ask the patient to stand and then By the way, in your interview, you will not be able to explain. You will just have to tell the headings. So what you can say is you'll ask the patient to stand and you'll check the patient from all three sides. Then that means from the front, from the back, and from the side. Don't try to explain what you are expecting. You will not have that much time. You hardly get 2-3 minutes to talk about this. And then you ask the patient to walk around the room so that you can check their gait or any limping. And you are trying to see if there is any kind of visible deformities, asymmetry, or change in skin color or warmth of the skin color, which you will be checking in the palpation. In the palpation, you will be usually you'll be checking for 4 things: tenderness, temperature, vascularity, and the capillary refill time. So basically what you do is you check if there is any tenderness, you check if there is any temperature, then you check the distal pulsation, and then you check the capillary refill time. If all of these are good, then the patient is less likely to have any vascular problems. The range of motion, this you can do to see if there is any kind of muscular issues. So you ask the patient to do the motions first themselves, and then after that you can do it yourself. One common screening test that I do, which is also part of the Ottawa rule for knee, to decide whether your patient needs any x-ray or not, is that I ask them first to stand, then I ask them to stand on the leg which is affected, and I ask them to hop. If they can stand on the leg which is affected, they can hop as well with minimal pain. It's less likely to be something dangerous. If they cannot stand on that leg, or they cannot, they would not be able to hop at all, then that definitely requires some imaging. So something that you can include as part of your screening. The other thing that I ask the patient to do when they have knee pain is I ask them to squat. Can you squat? Because squatting involves all the movements you require in the knee. If they can squat without much problem with minimal pain, then again, maybe it's a muscular injury. If they cannot, then I will be diving deeper into that. Special test. Learn the names of some of the special tests and also learn how to do those tests if you are asked. Some of the tests that we do in case of knee injuries, the common ones I will tell you: anterior drawer test, posterior drawer test, medial valgus and varus stress test. Then you'll be doing the McMurray's test for the meniscus, and then you'll be do the patellar dislocation test and Clark's test for the patellofemoral syndrome. So make sure that you know name of this test and what each one of them tests, what each one of them checks. You can also check for the patellar tendonitis. I don't recall the name of that test, but what you do is you just push on the superior pole of the patella so that the inferior pole lifts up, and then you feel the patellar tendon there to see if there is any pain. If there is pain, then you know that is patellar tendonitis. Also feel the tenderness over the tibial tubercle, because the epiphysitis pain or the stretch pain because of the stretching of the muscles happens there, which is one of the hallmark sign of the osteodysclater disease, and that's what we have positive in this case. So just mention what test you want to do, and they will give you the positive findings after that. So neurovascular examination, as I said, I do the neurovascular examination when I do the palpation, because if I'm touching the patient, why not finish all of that at the same time? Generally, the way we do the test in musculoskeletal is look, feel, move. So whatever I find relevant, I do them at the same time. Now, these are some of the differentials that we have to consider in this case here. The first one is osteodysclater, the condition that we got in the exam. This is a case where there is progressive anterior knee pain, which gets worse with the activities. Patellar tendonitis, a jumper's knee. Usually these are people who are jumping and running around. Based on the symptoms alone, you may not be able to make the diagnosis, but if you do the examination, you may find the tenderness at the inferior patella, and there is pain on the resisted knee extension. Sending Larsen-Johansson syndrome. This is the anterior knee pain which worsens with the activity. This has swelling and tenderness at the inferior patella, pain and resisted knee extension. Patellofemoral pain syndrome. This is again the pain in the anterior aspect of the knee, and this gets worse when the patient is sitting, squatting, or when patient is climbing up or down the stairs. In this one, we do something called the Clark's test, where we ask the patient to do, we just squeeze the top of the patella, and then we ask the patient to contract their front thigh muscles, and that causes the pain as the patella grinds over the underlying condyles, femoral condyles, and causes the pain. Stress fracture of the proximal tibia, you just have to compress the proximal part of the tibia and there will be localized pain there. This condition requires an X-ray. Osteochondritis dissecans, this is a condition where there is a loose fragment of the cartilage that is in the joint, and because this is just floating around, sometimes there can be locking is when it comes between the two bones. Most of the conditions here, for example, will not require any imaging. We do the imaging if we are not certain about the diagnosis. Now, generally, if you are not sure if the patient has any fracture, you go for the X-ray. If you are not sure if the patient has any soft tissue injuries, the first test you can do is ultrasound. Why? It's cheaper, it's easier to do. What if the ultrasound is negative, but you have a strong suspicion and the patient is not getting better? Then you can do MRI, which is a better version of the image you can get from the ultrasound. And treatment. Most often the treatment is conservative management. And regarding the conservative management, you need to learn some basic principles of conservative management. The basic principles of conservative management can be summarized with the mnemonics POLICE. P-O-L-I-C-E, POLICE. P stands for protection. Protect your joint. Don't get it injured further. Which means maybe in the initial phase of inflammation, you may need to practice immobility, maybe take rest, which is usually the first 48 hours. So initial stage of inflammation and pain, take rest. OL in POLICE stands for optimal loading. Once you start feeling better, try to move the joint through the range of movement as much as tolerate to avoid any stiffness of the joint later on. Then after that, I means ice. Use ice wrapped in a towel so that you can get rid of the pain and the swelling. C means compression. Use the compression. You might use the compression bandage. That can help you with the pain and might give you a bit of the protection and stability of the joint. E is elevation. Elevation will improve the blood return, and then that will improve the swelling as well. This is called the POLICE principle. In addition to this, offer analgesic to the patient, especially in the acute phase. You may need to give some prescribed pain analgesics. And then after that, they can take over-the-counter medications. Offer them physiotherapy. That will help. Physiotherapy helps in two ways. It helps in improving the stretchability of the muscles and also improves the strength of the muscles. These are just a basic overview. Of course, there are more than this. And if patient needs to be resting that particular joint, offer them crutches. If you think that the patient needs to give rest to their knees, then how will they do that? You have to give them crutches. So think about these things. That way you will have a very comprehensive idea about how to manage these cases. And in most of the cases, the treatment is going to be the same. So just a brief overview of the different conditions. You'd have this in your note anyway, so I'll skip this for now. Our provisional diagnosis in this case is osteochondritis disease because of the localized pain in the tibial tuberosity. By the way, this will be given by the panel to you. After you talk about your examination, they will tell you that your patient has full range of movement, no neurovascular compromise, but there is localized pain at the tibial tuberosity. And the idea is clear. This is a case of osteochondritis disease. Now, what would be the management? Management of osteochondritis is conservative management. Patient has to know what is happening. They may need to make some changes in their activity. Pain should be controlled, and there should be a gradual return to the sports. So how you are going to do that? Tell them that they can take painkillers as needed. They should be using some protective kneecaps or things around the knee so that they do not end up using it too much and cause further damage. That can provide a bit of compression as well. They make sure that they wear proper footwear with good arch support. Then you send the patient to the physiotherapist who will help them with improving their flexibility and then improve the strength of the muscles. They can start with the ice, which is generally something that people use. There is always a confusion. Should we use ice or should we use the heat therapy? Generally, in the acute phase, it's better to use ice because it helps in settling down the inflammation. Then after that, you can use the warm therapy. Then tell them that before they do any exercise, they do any kind of sports activities, they first have to warm up their body before they start doing it so that the body gets enough time to get ready for the activities. And then about the rest, as I told you, that they should be providing enough rest to the joint or the muscles or the ligaments that they have injured, but they should not be giving too much rest because that can cause stiffness. Now, follow-up appointments, you can decide when you want to see the patient back. Generally, in these cases, I give them about a week to come back to see if they are not getting better. I tell them that you will not be completely free of pain, but your condition should be getting better by the end of the week. If it is not, if it stays stable, or if it starts getting worse, then you need to come back and we'll have to do some imaging. This is what I generally tell them. If it's getting better, even if you are not fully recovered, that's a good sign. It will just take time and it will get better with time. In this case, because our patient is a sports player, so we have to tell them that you have to be careful about your return to the sports. Give yourself enough time to get to recover your strength and stretchability of the muscles. You can start with some light exercises and activities first, and then you can see how much you can take at one time and gradually increase your activities. This is something they are going to ask us in the exam as well. They will ask us like, okay, the patient wants to start playing the basketball. When do you think it is the right time? That question, when do you think it is the right time? We often feel like, so should I say 2 weeks, 3 weeks? No. It's not about how many weeks. It's about when your patient is ready. The concept is the patient should be ready to go back to the activities. So that means the patient will determine when he's ready. As a doctor, you can only assess their range of functions, whether they have improved or not, or if they have any residual injuries. But the patient will determine when they are ready to go to the next step. If they can, if there is you are not concerned about any residual damage and the patient is tolerating the pain quite well, it's better to ask them to get mobile as quickly as they can. Imaging, as I said, in most of these cases in the exam, whether they are the shoulder cases, hip cases, or knee cases, they will ask you, do you want to do x-ray? Do you want to do ultrasound? What you need to remember is, in cases of the fractures, you will do x-ray, of course. In cases of the muscle injuries and ligament injuries, the imaging is not going to change your management as such. Why? Because most of the times you are going to tell the patient to take rest, take painkillers, go for the physiotherapy, protect your joints, all those police principles. So by asking them to do the, let's say, ultrasound, which is a bit cheaper, or MRI, which is quite expensive and takes a lot of time, you're just wasting the resources. So what you need to know, when these people need to get this imaging done. Imaging is done in two circumstances. First, when you are not sure what is happening. In exam, you can't say that I'm not sure, by the way. If you are feeling unsure, just say that I think that the patient has, let's say, the ligament tear, but I'm confused by this fact. So I want to discuss with my supervisor whether we should be doing an ultrasound here to start with, and perhaps an MRI later on if we cannot see anything in ultrasound. This is the safe answer, safest answer. The other situation is when your patient is a professional who depends on that joint. And so who are these people? So let's say that Taylor is a state level player. He's not just playing basketball as an amateur for his hobby. He actually intends to have a career in basketball. So these people will depend on their joints. They will depend on the the recovery of function of the joints. These kind of people needs more attention. So we have to do the imaging. We also have to refer these people to the orthopedician for the repair. So because this is a very common question, do you think he requires surgical repair? Do you think we should do imaging? Depends on who he is. If he is someone like us who just needs to have the basic function restored, but we are not worried about the accuracy of the use of that joint, we will not be worried. If he is a professional, then definitely we would want to take that into consideration, because this can be a life-altering moment for them. And for other common people, referral to specialist is when the condition does not get better with the conservative management. You have already given enough time to the patient. The condition is stuck there. It's not getting worse, but just stuck there, or it's getting worse. Then in that case, you can send to the specialist for the further management or for the evaluation and opinion about the treatment option. Okay, so this is the case of the knee pain for a 13-year-old patient. I hope I have addressed some of the common things you may encounter in the exam. If anyone has any questions, please feel free to either post in the chat box or simply ask. Unmute yourself and ask. Generally, in the question you are asking is actually about the WHO pain ladder, analgesic ladder. So if you look at the analgesic ladder, they we start with the no no we start with the PCM or NSAIDs, and then after that we go to the mild opioids, then we go to the moderate strength, and then we go to the what do you say, more potent opioids. So we just step up the ladder. In any part of the ladder, we consider the use of adjuvants. Like some of the commonly used adjuvants are the steroids and medications used for neuropathic pain management. For example, the medications like pregabalin or gabapentin or this amitriptyline, this kind of medication. So you start with the PCM, and if you feel like the patient is not responding to PCM, allergic to NSAID, the next step would be to start with a mild strength opioid or weak opioid. Perhaps I will consider giving them codeine, or I will consider giving them tapentadol. These medications can be good enough for some. If that they are not responding to that, then I can step that up with the tramadol, and then after that maybe step up to the oxycodone and so on. So basically the idea is to go in a stepwise manner. And every time what we have to remember is every time we step up, we should have a step down plan as well. That means like if I'm putting my patient on oxycodone, how long? How long do I want my patient to take that? And when I think the patient should step down. Because one of the reasons patients become dependent on this kind of medications is, look, okay, you give oxycodone to someone who has pain, of course that takes care of the pain. And the moment they stop taking the oxycodone and go to something, let's say celecoxib, or let's say go to the paracetamol, they will have a little bit of pain. So obviously when they compare, they will be like, okay, when I take oxycodone, I don't get any pain. When I take paracetamol, I get some pain, which means oxycodone is better. So what we need to tell them is the intention of starting the patient on oxycodone is not to make them pain free, but to make them be able to do the activities they can tolerate. What we have to tell them is they should have a realistic expectation. They may not be completely pain free in 1 week time. We are just trying to take care of the severe pain. We are not trying to make them pain free. One of the common reasons these people become addicted is because of this misunderstanding, because they think that they should not have any pain at all. And now pain is not just a physical sensation, as they say, it's a mental sensation, it's a cultural sensation. How much pain you feel depends on several other factors than how much injury was there. Your own attitude towards the pain. That's why they say that if you don't want your patients to become addicted, tell them exactly what is going to happen. So tell them that you take it for 3 days. During this time, you'll have very bad pain. And then after that, we'll gradually taper you off this and we'll increase the dose of the analgesic. This one for, NSAID or maybe paracetamol. Even after taking this, you may have some pain, but we want you to recover your function and start doing your activities of daily living as tolerated. You may have some pain left even after 2 to 3 weeks, but as long as you can do the activities you want to do without feeling distracted by your pain, that is all right. Eventually, you may be able to ignore the pain or may completely get free of the pain. Generally, the research has found that if someone has used opioid for 3 months, they actually lose their efficiency, their efficacy. So they do not actually work, but the patient becomes dependent. So what if the moment they stop taking the pain medication, they feel like they have the pain, although actually the opioids are not doing anything for them. An interesting case happened to one of my patients who was an immigrant from UK. So this patient was taking opioid for almost 2 years, and I feel good to say that I was able to de-addict this patient from the opioids he was taking, which was a lot of discussion with the patient, a lot of convincing, motivating the patient, and eventually he was happy to try something else. I tried to explain to him what pain is. So basically, I was not telling him about the medications to use for managing the pain. What I was telling him was about what pain is, how our brain perceives pain and interprets pain, and how our cultural background, our attitude towards pain affects it. So gradually he started lowering the dose and he eventually went off it. And when I asked him, like, what made you feel like you could do well without using the pain medication, he was like, when you told me that, I'm more thinking about the pain in my head, and when I don't take the medication, I just feel empty and I feel like I have to do something because I have pain, and that's why I feel the pain. I thought about it and I tried to go without it for 1 day. It was quite tormenting experience for me, but eventually I felt like I could do without it, and that's how I got out of it. Now, not every patient will be able to do that, of course, especially patients who have been dependent on this can have withdrawal symptoms, sometimes severe one. But I mean to say that sometimes, if you help them understand what they are going through, they might be able to pull it through and might get motivated enough to bring some changes in their life. Now, the next is there a specific cases for each provider? As these topics that we discussed today are common cases with IME provider. Yes, there are some cases which are more popular with some providers, but I am always against going by the recalls focused on specific providers, because the providers have become smart enough to realize that many people actually memorize the cases. That's why what they do is they give you the exact same case the previous candidate got, but they will create twists. And people who rely just on their recall rather than their understanding of the case usually are the ones who are likely to fail in the exam, because people who are assessing you are smart enough to know that you are just going by the format rather than by the information offered to you. So what I generally tell people is, okay, if you have a case of, let's say, a 13-year-old boy who came with the knee pain, don't take that as a case of let's say the osteosclerotic disease. Take that as a case of knee pain in adolescent. Knee pain in adolescent, what are the differentials? What is my approach? How am I going to do this? After some time, the cases do not really matter to you. What matters is, do I have enough information to present? So whether it's IME or RCGP doesn't really matter after that. And the other thing is, anyone who has gone through all the cases I have on the website and has made sure that they have the good approach, I'm confident that they will not fail the exam. I have never delineated the difference between IME and RCGP when I do my cases or case discussions. My people who have joined my courses have done IME and RCGP both, and they have succeeded in both. So, and the only thing I tell them is just understand the concept, not the case for IME or RCGP. You'll be all right. Yes, some people like that, some people don't like. It's fine. People who don't like, they have their own way, their own reasons, and I don't want to argue with them. But I also don't want to change anything in the way I do things. I don't believe that we are preparing for IME or RCGP. We are preparing for general practice in Australia, and both the providers are supposed to see whether we are good enough to work as a general practitioner or not. So the underlying principle is same, only the way they are doing it is different. So learn the differences in their assessment method, not the differences in the cases they ask. Okay, anyone else? Any other questions? Feel free to ask me questions in our Facebook group. I'll be more active for the coming days. I'll be more active on my Facebook group than on the Telegram group. So feel free to ask. I have added almost all of you who I could remember to the Facebook group. If you have not been added, let me know. I'll add you there. I'll be answering your questions there more than in the Telegram group. I'm finding it a bit difficult to answer in both the places. It's a bit confusing. So I have decided to focus only on one platform, because I personally use Facebook Messenger and Telegram I only use for this PESCI and AMC clinical exam discussions. That's why I've decided maybe I'll just bring everything in one place and then start answering the questions in one place, just to make it easier for myself. Yeah, that would be all from my side for today, unless anyone else has any other questions. Sure. Mm. 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 Okay. Okay. IME, I think, this is my personal opinion again. IME, I think you are more likely to benefit from IME exam if you are an interactive person. You are more likely to benefit from RCGP if you are an articulate person. The reason is RCGP asks you to present. That means there will not be two-way interaction. You'll just be telling what you want to do. there will not be anyone answering your questions. IME, on the other hand, it has a mixed approach. They ask you to present, which is fine, which is similar to RCGP. You just tell what you want to do. But they also want you to ask, they also ask you to speak with the patient. That means they do the role plays as well, which means you have to be interactive at the same time with the patient, like how to respond to the patient, listen to the patient, ask questions, pause, reflect, ask more questions, and so on. So that is the basic difference. The other thing is RCGP, because RCGP does not have a role player, that means, and then they give you 15 minutes time, they have more time to assess you about the depth. So that's why their cases are more, have more depth. They go into more depth while assessing you. IME, because IME, you have a two-way discussion, so you have less time. That's why they are more about your overall performance. Like they want to see how you would do if you were a doctor in Australia, you're a GP in Australia. So that is the basic difference. But let's say that you get the osteoarthritis case in IME and osteoarthritis case in RCGP. You need to know the same basic things to pass both the exams. It's just how you would do it would be different. Any other questions? All right, we can always have these question answer sessions anytime in the future as well. Just feel free to ask me questions, as I said, on the Messenger group more than on the Telegram group, and I'll be happy to answer your questions there. That would be all for today. This Thursday, I'm doing another session. This is especially for people who are preparing for AMC clinical exam. And I'll be focused on the AMC clinical psychiatry. This is based on the new psychiatry course I have just launched. Anyone who is interested can join it. I will be mostly talking about how to do the psychiatry history taking, and then I'll be talking about the psychiatry mental state examination. In your AMC clinical exam, one case will always be mental state examination. If there is one case that comes in every exam, that is mental state examination. How to do it, how to present it. You learn how to do that. You only have 8 more cases to worry to pass the exam. So make sure you attend the session. And if you have any questions, please feel free to bring. The session will be shorter than this. I will only be doing it for 1 hour because we'll be only talking about 2 different topics. And then mostly I'll be answering your questions. Okay, with that, I would like to conclude today's session. It was good to talk with you all, and I hope I have been a bit helpful for you. All the best and good night.